afternoon, everyone. It looks like we are right at the top of the hour. So in respect of everyone's time, we'll go ahead and get started. I just wanted to welcome you all to our Back to Basics webinar series. For those of you that have joined us before, we are very glad to have you back. And if this is your first time joining our webinar series, we're glad that you're here as well. This webinar series is focused on helping healthcare providers across the continuum of care use lessons learned from the pandemic to improve chronic disease management and outcomes. And today's session, we are going to cover chronic disease and the impact of substance use disorder. We would like you to take a minute to please enter your name, your organization and facility, and your role in the chat so that we know who is joining us today. And I'll just introduce myself. My name is Andrea Boucher. I am with Superior Health Quality Alliance on the Chronic Disease Management team, and I'll be your facilitator for today's webinar. And I am also joined by Rachel Dibble, who will be our presenter for today. So really quickly, as I mentioned, today's session is part of a webinar series. We do have these webinars on the third Tuesday of each month, and we have two sessions, the first at 12 o'clock Central, 1 o'clock Eastern, and the second at 3:30 Central, 4:30 Eastern. And on this slide, you will see some of our future topics that we're going to be covering. And our session next month is going to be focusing on immunizations and chronic disease. In September, we will be covering tobacco cessation and the 5A's intervention. In October, we will be talking about Z codes and social determinants of health. So just want to note that this schedule could be subject to change if we do have any important or time-sensitive information that does come up that would warrant a session in an earlier time. We also would love to have your feedback. If you do have any suggestions on future topics that you would like to see us cover, you can feel free to drop that in the chat box or send us a private message or get in touch with us on any suggestions you have for future sessions. But I will go ahead and I will turn the floor over to Rachel.
Thank you so much. Welcome, everyone. This topic is a very broad and in-depth topic. However, today we will just get a sense of where the topic lies and some interventions and some education surrounding opioid and chronic disease use. So we'd like to start with a polling question just to get a baseline of your thoughts with this question. So I'll give you a moment to answer the question. So the question is, which of the following of chronic diseases are chronic diseases rather? That is terrific. Thank you so much for that. So that gives me a nice idea of where everyone is. Next slide, please. So our objectives today are describe the prevalence of substance use disorders within commonly identified chronic conditions, discuss how chronic conditions can lead to either mental health issues or substance use conditions, discuss how mental health and substance use disorders can impact treatment of chronic conditions, and finally, explain the importance of coordinating care in patients with multiple chronic diseases, including mental health and substance use conditions. So the background concerning the topic relates to chronic diseases and opioid-related hospitalizations are on the rise. I believe that is pretty across the United States, and it is a major driver, particularly with Medicare. Patients with 2 or more chronic diseases and opioid-related hospitalizations were white and in urban hospitals, and I will add communities as well. So patients with 2 or more chronic diseases, they accounted for 90% of opioid-related hospitalizations. Next slide, please. So opioid-related overdoses in the United States were estimated at 70,000 deaths in 2020. Chronic pain afflicts 1/3 of all adults, and people suffering with substance disorders must have access to treatment. On this slide, I'd really like to highlight the pandemic. So COVID-19 has had a significant impact in mental health and people suffering with substance disorders. Also, Medicare plays an important role in ensuring beneficiaries with opioid disorders have access to treatment. So as we know, with the pandemic, and I want to point out, particularly in this population, pain also relates to mental health pain or emotional pain. So when you have that coupled with chronic diseases, potentially substance disorders, the pandemic has significantly impacted this patient population, and also getting assistance, particularly with lockdown. It was very, very hard to get into a mental health provider and or specialists for chronic diseases. So that is a big takeaway, because COVID-19 and long-term COVID continues and will continue. We do not have the data on this as of the moment, but it's something to think about when you have folks with comorbidities and mental health issues. Next slide, please. So chronic pain. Obviously, as we know, our population suffers from chronic pain. So when chronic pain is left untreated, pain can become more complex in its pathophysiology than pain caused by the original injury or disease. So this can both have physical and psychological consequences for patients. The significance economically, the impact due to increased costs of healthcare and loss of productivity. And productivity really can mean obviously going to work. It can mean basic ADLs, for example, people falling so that they are out of work longer, and then the medical system insofar as assisting these folks to basically help them with their productivity, possibly injury. So there is a significant impact with the economics and really all facets of one's life. So that's something that also can relate to mental health, major depressive disorder, in particular, then getting people back up and rolling after a situation with chronic pain. Next slide, please. So the consequences of chronic pain, I mentioned a little bit earlier, patients are at risk for developing further complications, including altered mental status and physical dysfunction. And that is, for example, without opioids. So folks with, again, major pain, they oftentimes, they just can't even speak when it is that extreme. Also, altered mood, anxiety and depression can be created by chronic pain, but it also can be exacerbated by chronic pain. Major depressive disorder, same situation with substance, it can exacerbate with chronic pain. Suicidal ideation and suicide attempts. I will stop there, particularly with white males over the age of 70. And if they have recently lost their spouse, their statistics are about 70 to 80% with suicidal ideation, suicidal attempts. And that can be even without a baseline situation of mental health issues. So impaired memory and sleep, that is something I'd also highlight. Actually, this is something that, of course, you know, it is out there, but when I did the research on the impaired memory and sleep, it was super interesting. Pain increases, of course, when you do not have enough sleep. Just someone who does not have chronic pain, I'll use myself as the example. If I don't get enough sleep, I feel achy, almost flu-like. So that's something that with sleep hygiene, we can mitigate in these patients with chronic pain. Cardiovascular health, impaired sexual function, and then sleep dysfunction as well with chronic pain. Next slide, please. So what is chronic pain? So the American Pain Society and the International Association for the Study of Chronic Pain states, pain that persists beyond the normal tissue healing time, which is assumed to be 3 months. And what that means is, for example, if you had a hip replacement, so if it persists over 3 months, then that falls into the category of chronic pain opposed to acute pain and tissue healing. A sprained ankle would be another example of that, normal tissue healing time. So when it's extended past 3 months, you're really looking at a chronic pain situation. Next slide, please. So common diseases with chronic pain. So a broad variety of common conditions with different pathophysiologies are associated with chronic pain, including cancer. Cancer is a big one. Usually that is metastasized, usually in the bone, but there also are cancers that are being treated with, that are curable, but they go through a lot of chronic pain in that. Degenerative spine disease, I will go specifically into lumpectomies, which you see a lot of folks having. Those surgeries sometimes work and sometimes don't, and can cause more chronic pain as well. So that would be something to look out for if a patient says, I've had back surgery. Osteoarthritis, of course, that's arthritis in the bone. Fibromyalgia, HIV, migraines are also something to point out. Diabetic neuropathy, that is a big one insofar as neuropathy, to be treated, for example, with a gabapentin, which is the med to go to, sometimes it doesn't work. And then you might have a patient who says, I've had a substance disorder and I'm not going to go on opioids. But the neuropathy can be debilitating for these folks. Also post-hermetic neuralgias, so that is shingles. Shingles, I've seen a lot of patients who cannot get rid of that nerve pain. And it is extraordinarily debilitating for these patients as well. So something to look out for: diabetes, have they had shingles, maybe some back surgery, and then of course the cancers. Next slide, please. So the impact on mood disorders and mental health. Prevalence of psychopathological disorders ranges from 33 to 46%. So patients with chronic pain are more likely to develop psychological disorders than those without. So that's not baseline, they already had it. It can be created. So populations with chronic pain are higher with those who have, of course, depression and major depressive disorder. And that is physical pain and psychological pain as well. Next slide, please. I like this image for a lot of reasons. So this is an example of chronic back pain. So the people in the middle are the folks with chronic back pain. The people on the right are folks who, for example, have not suffered from a comorbidity. And I'm so sorry, excuse me. And then the ones on the left with the normals. So what that, if you look at the red and the blue, this is what opioids will do for someone who is at risk. So you see on the right with the chronic back pain patient, it's not lighting up too much here. But someone who has a comorbidity of mental health issues, they are completely lighting up, which means that they have a huge risk of substance abuse disorders, dependency, etc. So this image is something that really sticks in my head for years when I think about what opioids do to certain populations, and particularly if they are on long term. So I think it's a great image to see what actually happens in the brain and the addiction centers within the brain. Next slide, please. And the impact of chronic pain on brain function. So when we think about the consequences of chronic pain and opioids, we have to understand too that we are actually changing the structure with some of these drugs of the brain. So that impacts, of course, your cognitive processes, meaning your memory, recall, etc., brain function, and central neural systems. Cognitive processes have been shown to be impaired in up to 2/3 of patients with chronic pain. So that also means balance in particular, insofar as falls. So I will highlight falls with that. Memory disruptions. That's also very, very frustrating for patients, particularly when they are maybe mild or moderate Alzheimer's dementia. They will think perhaps it is the disease when really it is the opioid that's exacerbating the chronic disease. So sensory changes are also specific to regions of the brain. And that was the slide before, where it really shows the actual change of a brain when opioids are prescribed. And it really does change the structure. So the perception of pain and behavioral aspects also are very much associated with pain. So I will say that the perception, particularly if you have a baseline mental health issue, it is maybe a perception of pain because it's really a mental health pain. So really understanding that and guiding patients to the right help if needed, and some ancillary, maybe some, psychosocial or psychologist, cognitive behavior therapy as well, will assist with the perception of pain and the behavioral aspects of pain associated with that. Next slide, please. So the impact of chronic pain on sleep, which I discussed before, and this was a really good learning that I learned, and it makes sense to me. So disturbed sleep is common, occurring in 50 to 89% of chronic pain patients. Sleep disturbances can be directly related to the severity of pain. So in a study of 268 consecutive patients with chronic low back pain, not even the moderate or the high, their pain intensity was found to be directly correlated to the degree or hours of sleep they are getting. So if you think about this, so say they're on opioids, they are just low threshold for chronic pain, and maybe they're just on opioids for say 7 days or 3 days. They don't sleep well. So then you start into another cascade with the chronic diseases, in particular, say the musculoskeletal diseases, fibromyalgia, back pain, etc. They are at high risk of particularly falling, and that for some patients can be the decline of their life, affecting their quality of life, and then the downhill spiral starts. So the key here is that early treatment of chronic pain is important to minimize these sleep disturbances. Of course, that goes for many other symptoms, but if we can catch it early, then perhaps they don't have to be on a high dose. And then we can taper up if needed. If not, leave it as is. Next slide, please. So the intensity of chronic pain is statistically significant predictor of hypertension. So again, chronic pain affects the cardiovascular system. So that may, to one, say, how is that possible? If someone is in chronic pain, typically their heart rate is higher and their blood pressure is higher. So maybe they didn't have hypertension to begin with. Opioids or a non-pharmacological intervention has not taken place. So this person that used to run at maybe 160 or 140, hypothetically, it's 160 is high, is now running at 180. So then we look at stroke in particular, we look at MIs, we look at kidneys that can damage your kidneys in particular as well. And if they're diabetic, then you can really see the trajectory of what may happen to that patient. So the risk may be related to altered pain pathways and cardiovascular function, because as we know, pain does disrupt the pathways in the brain and alters the structure, and particularly with opioids. So patients with a history of coronary heart disease increases the risk of cardiovascular morbidity, and that really can't be true enough. So when you have someone, for example, if you even look at their medications, or their son say, oh, hey, they had a cabbage or open heart surgery 6 months ago, these are things that should be going off of, maybe we should look at this and really monitor the blood pressure. And perhaps they have to go up on blood pressure medications to get the blood pressure down and to get the chronic pain down. So it's a fine line and somewhat of a science here. Next slide, please. So impact of chronic pain on quality of life and functionality. We just went over that a bit, but I'll go through it here. There are some added red flags, if you will. So in patients with chronic pain, overall quality of life, it is simply diminished. So quality of life is affected by chronic pain, including social interactions and daily activities. So that again can exacerbate mental health issues, isolation, depression, etc. So personal relationships and employment status. So that goes back to your economics, particularly people that also that are on fixed incomes. Sometimes it really impacts their quality of life fiscally. So the frequency of interference with social life, work, and daily activities, and the importance to effectively manage pain in its early stages before it progresses to further to affect the patient's function. So those are some things to really, when you look at a patient in a 360 view, those are some other things to look at other than the actual specificity of where the pain is. Next slide, please. So the impact on sexual health. So impaired sexual function, it's reported to be 54 to 63% of individuals with chronic pain. So the issues that come out of that with sexual function, or dysfunction rather, and chronic pain are difficulty with arousal, confidence, fear of worsening pain, and then relationships, which could also equal isolation, and then the cascade of depression, anxiety, etc. Next slide, please. So what are the recommendations to ensure monitor risk stratifications? So the guideline states that it is the urine drug screening, or UDS, is based on risk stratification and is no longer required at every monitoring visit, except for patients in the high category situation. So UDS is required annually for patients, even in the low intensity group, at least every 6 months for moderate, and at least every 3 months for high intensity. I want to pause here just for a second. This can be a very sensitive topic and maybe even uncomfortable for the provider to suggest. But the idea here is that we don't want to over-medicate, and we need to ensure that maybe polypharmacy isn't happening. In older populations, people just get confused. They don't remember that they took their hydrocodone this morning, for example, and they may continue to take them, not prescribed as the increments of when they need to take them. This is really a situation to keep them safe. Also, I think I get to the next couple of slides, the monitoring system. So they are state to state. So if someone, for example, has a doctor in Kentucky and they're being prescribed opioids, I won't know in Tennessee. So talking to the patients, really making this as not punitive. We'll talk about it a little bit more, the stigma related to this. This again is a safety measure for falls, overdoses, exacerbating chronic diseases. So I think that is a big takeaway, and it's hard as a provider and a patient to really go, okay, I get that it's a safety issue and not punitive. Next slide, please. So updates to prescribing as of May 2020 in mental health. So patients prescribed long-term opioids are required every 3 months to review their safety plan with their provider in person or video. So that's different from being tested. That is the plan of ensuring people are safe. So the criteria for high-risk opioid use were expanded in this new guideline. So added risk factors, and I'm so thrilled to be saying this, is that they have added mental health conditions, depression, anxiety, PTSD. It was a long time coming and they have done it. So medical conditions, of course, too, are obesity, sleep apnea, big one, because obviously people stop breathing with apnea. And so if you add opioids to that, the respiratory system automatically decreases. So you've got those two things to look at to ensure that that we're not over-prescribing or that we can monitor appropriately. Alcohol and illicit substance use, thrilled that they've added this. And then, of course, the advanced age. And that's just an overarching to really be mindful of those folks who are of advanced age on opioids. Next slide, please. So management of chronic diseases. So what we want to do is reduce the complications with chronic diseases when pain is present. Early detection and effective therapy offering the potential to avoid or to reduce long-term consequences, and controlling pain through the use of both pharmacological and non-pharmacological therapies have also shown to improve sleep, depression, exercise performance, cognition, and overall quality of life. So the key here is the early interventions. Next slide, please. So strategy, care coordination is really the big strategy here. The idea is all hands on deck. So in that, we use an interdisciplinary team. We establish opioid policies and standards. We create a standard treatment agreement for all providers to use and develop a policy on the threshold dosages for patient population. And I'll just stop there with a lot of the guidelines already, or most of them already have this. So it's not something you may have to come up with. And what we also want to do is encourage patients already at high levels may be willing to try reducing the dosage. And that's also the key. But again, it's a fine line there. Prescription refill or renewal policies and policies for frequency of urine drug testing. Again, not a punitive exercise, but rather let's keep you safe. So policies and procedures for checking the prescription drug monitoring program. I just touched on that. And it's a great tool, but it typically does not go over state lines. So that is something to look for. Next slide, please. So in summary, chronic pain has numerous long-term physical, psychological, and economic consequences. Priorities and standards of therapy for the management of chronic pain should consider the effects of patients' health and overall health, and have the goal of improving long-term outcomes through early and effective interventions. And as a provider myself, I will say that looking at the patient holistically, head to toe, that is usually a sure way to be able to touch on all the things that could happen from, the social aspect, economic, down to the actual pain. Next slide, please. So as we know, there is a huge stigma surrounding this. And in that, I would really encourage people to take the pledge. Words matter. So we are asking individuals and organizations to commit to changing the stigma around substance use disorder. And this is a big deal, and it will take all of us to move the needle. So please take the pledge and learn about stigma, and also using non-stigmatizing language as a whole. So using Superior Health's Shine a Light on Stigma promotional media toolkit is a wonderful way to learn about this and to help invite more people to join the effort. There's a lot of myths out there, and I believe it is our job to squash the myths and destigmatize the issues surrounding opioids and chronic diseases. Next slide, please. So I'll open it for questions. I thank you so much for joining us. Does anyone have any comments, questions, experiences they want to share?
Thanks so much for your presentation, Rachel. I'll just remind everyone, if you do have any questions or comments, you can feel free to either unmute and share or ask, or add them into the chat. And while we're waiting for those to come in, we do have a couple of links being added into the chat. So Rachel did just mention our Shine the Light on Stigma campaign. The link for that is in the chat. And like Candy said, I've also taken it. It doesn't take too long to do that. So if you do have a moment, we would love for you to do that for us.
And this is Candy. If I can just add to our website, if you're wondering what it's like to hear from people's real lived experiences about what it's like to go into healthcare and be treated with such stigma because of opioid use disorder, there's some stories in our website that literally will bring tears to your eyes as a healthcare professional, for sure. So just want to encourage that.
Definitely worth a review. It's poignant when it comes from the person or the patient. Just a little ad there, Candy. Or Jerry, sorry.
Absolutely. No, thank you. And thank you for your presentation, Rachel.
You're
And
welcome.
I was going to say, Rachel, great presentation. I really like how you, I feel like you gave us things to think about, because, we think of opioid use disorder, and as Candy was just saying too, and the stigma attached to that, but how there are so many chronic conditions and chronic diseases that how it's just a kind of that fine line from one side to the other, and how that can lead to a opioid substance use disorder, excuse me. And I think your presentation contains so many things, I think, that will help providers kind of look at that when they're treating patients with chronic conditions, and kind of what to look for. So just interested too, from those who still are on the call, any thoughts on that? And especially too, looking at substance use disorder as a chronic condition, which it is. So. A quiet crowd today.
Rachel, this is John. I'm wondering if you could speak at all to, those UDSs and the frequency of them. I'm wondering if perhaps doing those more frequently as part of the treatment plan might help decrease some of the stigma around that.
Absolutely. That was the guide. Guys, I'm so sorry. I know I just yelled at my child and I wasn't on mute. I'm so sorry. He was acting up. Yes, absolutely. So that is the guide. However, when you're, say, monthly monitoring the patient, that's where that is really the place. If you think perhaps they're having side effects or more depression or whatever it may be, it would be appropriate to do with the explanation that again, we need to tweak your dosage. It's just like, for example, if someone has a significant mental health issue, it takes a minute to trial and error. Like it is not it's not a one and done situation. And that, I think, is really the thought about opioids as well. So again, it's for the provider, community health workers. I've found them to be instrumental in, hey, I'm not sure, but I think something's happening. So it's really that interdisciplinary, all hands on deck, and when it's appropriate, if you believe you might be harming the patient.
Well, thank you, Rachel. I think you've shared a lot of really valuable information today. This presentation was very helpful. If you do have any questions or comments, feel free to continue dropping them into the chat box. I did just want to go over A couple of the links that have been shared in the chat. We do have our evaluation link that has been added in the chat. We would like to hear from you on how you think the presentation went today. So please take some time to click on that link and let us know how what you of today's session. And I'll just really quickly go over some final housekeeping items since I don't see any other questions or comments coming in the chat. Again, just wanted to touch on our future topics for the Back to Basics webinar series. Again, our next session is on August 15th, where we will be covering immunizations and chronic disease. In September, we'll be covering tobacco cessation and the 5 A's, and in October, the Z codes and social determinants of health. We would also love to continue the conversation. We do have our platform, Superior Health Connect. If you're not currently signed up on this platform, the link to join is at the bottom of this slide. And we'd love for you to join and be able to access some of our resources and continue this conversation with those in attendance here today, and also other participants that we have within our network. So we would love to see you join us on Connect. A couple of final reminders of other resources that we have available for you. We do have our Food First, Using Food as Medicine library of resources that are available on Connect. Again, this link is at the bottom of this slide where you can access all of those resources. As we know, nutrition does impact health, especially for those with chronic conditions. So there are a lot of great resources available within this library. And we also have some documentation and coding resources. So we have some related to a lot of the chronic conditions that we talked about today, chronic kidney disease, diabetes, hypertension, and also tobacco use. So if you're interested in taking a look at those and getting some tips and tricks on how to code for these conditions, those are available through the links on these slides. And just some next steps, as I mentioned, our next webinar in August. If you're registered for the series, you should have access to that. But if not, we do have the registration for both time slots on these sessions linked on this slide. Again, another plug to join us on Superior Health Connect to access all of our resources and continue networking with all of our participants and with your Superior Health team. And if you're interested in any individualized coaching, feel free to reach out to Jerry Hineker. Her email is on this slide, and we would be more than happy to assist you in any way. And in the meantime, between now and our next session, if you do have any questions, feel free to reach out to any of us on the Superior Health team. We are more than happy to help answer any of your questions or provide any resources or assistance that you might need. So with that, I guess I will do one final call for any last comments, questions before we wrap up for today. All right, well, hearing none, Rachel, thank you so much for your presentation today. It was wonderful. We appreciate you all taking the time this afternoon to join us. And again, feel free to fill out the evaluation and let us know what you think and let us know about future topics. Thanks, everyone, and have a great rest of your day.